most humbly and respectfully all the doctors, and they are very well-known doctors across the India. Today we have decided very brainstorming topic is a pulmonary rehabilitation. As you know that pulmonary rehabilitation is often associated with air pollution because air pollution is significant risk factor for the developing and exacerbating chronic respiratory disease. To moderate this webinar, we have my mentor and very eminent personality in the medical field, Dr. Arun Kumar Agarwal. He is the medical advisor, innovation and clinical research, Apollo Group of Hospital and former Dean Maulana Azad Medical College. Along with Dr. Agarwal, we have the very prominent personality like Dr. Ravinder Mehta. He is the founder, director, Bio, Chest and Sleep Capacity, head of the Integrated Pulmonary Apollo Hospital, Bangalore. And very eminent Dr. B.L. Serwal, Director, Professor, Microbiology, Lady Harding Medical College, New Delhi. And Dr. B.B. Gupta, he is a ex-chief physiotherapist and head CTVS Physiotherapy Unit, All India Institute of Medical Science, New Delhi. And presently, he is a senior manager consultant physiotherapist CTVS team, Fortis Escort Heart Institute, New Delhi. And very known Dr. Vinny Kantru is a senior consultant pulmonary critical care and sleep medicine, Indraprastha Apollo Hospital, New Delhi. And one more, Dr. Sudhir Kumar Gupta is a senior consultant respiratory medicine, Kailash Group of Hospital, Noida. Now I would like to over to Dr. Agarwal to moderate this webinar.
Thank you, Tiwari Saab. I think my special thanks to you again because this topic of pulmonary rehab is very close to my heart. And I think from time to time, I have been discussing with some of my colleagues who are in front of me. So obviously, um, Tiwari ji has already introduced, but of course, when one by one, whenever I invite my expert colleague, I will also be giving little introduction of theirs. But let me start that Double Helical magazine is a leading magazine which is perhaps covering vast variety of the topic in relation to health. And I'm associated with this for like 10 years, more than 10 years, and I can see the way under leadership of Mr. Tiwari, it has progressed. And perhaps from a very small beginning, now it has become a platform which is not only for the medical professional, but for the uh, part of society and but many of our colleagues are very much part of this platform. So this topic of pulmonary rehab is no doubt in Indian scenario, in global scenario is very important. And my friend, Dr. V.P. Gupta and Dr. Ravindra Mehta, I have been discussing with them and sometime with Dr. Vinukantru also, you remember. And the need is obvious because we are living in an atmosphere where perhaps if I talk about Delhi, Delhi is the most polluted city, supposed to be of the entire globe. And but the whole scenario all over India, except very few places which are lucky, we have bad pollution, as well as we realize that after it's not that Dr. Sherwal, you will agree with me that we had bad pollution right from the beginning. It is not only when we started declaring AQI, we became bad. No. If you try to recollect when we were younger, well, Sherwal is still younger, there is no doubt about that. But when we were still younger, that time also during some time of the year, there used to be black crowds and I remember I was in Kanpur Kanpur city, and when we used to get up, we used to sleep on the roof, and our white sheet used to be black, right? So that sort of pollution is there right from the beginning, but with the various factors being added, now we are living in a chamber which is all polluted, polluted, polluted. So lungs are very important for us because it gives support to the entire body. And can we do something so that we maintain our capacity of the lung in such a way that it cooperates with us, and then we remain as in association with all other organs healthy to a certain extent with the desirability, even in old age also. So I think I would like to start. Ravi, can you hear me? Ravi?
Yes, sir, I can hear you very well. It just took
Yes.
me a
So,
second to unmute. Yeah, thank you, thank you.
so I would like to start with you. We have been discussing with you the pulmonary rehab and various support system of pulmonary rehab. Would you like to give your vision of pulmonary rehab?
Yes, sir. So pulmonary rehab actually, as we say in medicine, is not a new concept. As you said, pollution has been there for many years. Similarly, pulmonary rehab was espoused in the West for at least 3 decades. I think we know will agree with me. The earliest guidelines came around the late 90s and so on. And in that, whatever it is very Indian in its thinking, whatever medications can't do, rehab will do. And so rehab basically takes all the extra aspects of the disease on the body. We think of lung as an isolated organ, but involvement of the lung will involve the heart, the muscles, psychology, how the organs interact with each other. Education is required for patients. All this together is stitched into pulmonary rehab, where the overall upliftment of patients happen. The crudest simile one can give is like a gym. And end of the day, you have to go there and have every muscle group and every part taken care of. So pulmonary rehab does that. So it's a comprehensive program meant to take people with lung disease where conventional science has maxed out and put a non-medical full exercise, education, and overall improvement program so as to uplift their overall status and give them back quality of life, have them have less contact with healthcare, less hospitalization, and so these are tremendous benefits of pulmonary rehab. Over to you, sir.
Thank you. I think you have highlighted the importance of pulmonary rehab, right? And well, if it is so important, where are we? I agree with you, but I think, in my opinion, this is a public health message to the entire society within India and all over, that if pulmonary rehab is so important, where are we as regard its public health message, as well as within our hospital? Vinay, Vinay, can you
Yes,
hear
sir.
me?
Yes, sir, I can hear you
Dr.
very
Vinay
well.
Pantlu is a very senior consultant in the field of pulmonary medicine and critical care, and from Apollo Delhi. Would you like to give your views?
Thank you so much for this kind introduction, sir. Well, pulmonary rehabilitation, as has been already explained by Ravi, sir, it is very, very essential part of the comprehensive program which we set our patients into. Despite the usual care, it is the need of the hour that we at least undertake this project and make it sure that this pulmonary rehabilitation is not centered in the premier institutes in metros only. So when we consider what is the current position of pulmonary rehabilitation in India, yes, there is an awareness amongst the healthcare personnel, but I think that is too much concentrated into the tier one cities. So the penetration into the villages, the tier three cities, and the primary healthcare personnel is not up to the mark at the moment. And this is the pulmonary rehabilitation maximum benefit has been seen for a chronic illness like COPD, which is more common in villages, considering their previous exposure to chula smoke, which is already there, and also the women the burden of COPD in women is very, very high, which is a paradox which many of the healthcare personnel also at the moment do not understand. So I think the pollution is a problem not only of the cities but also deep down into the villages. But the penetration of pulmonary rehabilitation at the moment is not actually, it has not reached where it should. In cities also, even if there is awareness amongst the healthcare professional and the patients equally, the patients sometimes they are not able to incorporate into their daily life because of the psyche of the people. So there should be more education of people as well as healthcare professional as far as the penetration of the program is considered. We already know that there are immense number of benefits of pulmonary rehabilitation, but how to penetrate that into the society, into the minds of the healthcare professional, well, that needs more education.
Thank you, Vinu. We are just in the first phase of our discussion. We'll be just talking about your individual views. And now I'll come to my friend, Dr. Sher. Sherwal is not only an eminent microbiologist. Tell me which post he has not occupied in India. If I try to enumerate, my God, he had been head of institutions of so many famous institutes, and he has contributed in a very positive manner towards all those institutes he has headed. And now, of course, now he back to Lady Harding as a very senior microbiologist and contributing not only for subject but for medical education in a big way. So, Dr. Sherwal, you being microbiologist, right? And microbiology has got a very important role to play as regard pulmonary health is concerned, because we are dealing with pulmonary tuberculosis, we are dealing with so many other kind of COPDs and so many other infectious disease, non-infectious disease affecting the lung. And what had been your view, Dr. Sherwal, that beside your subject, what are the main factors that perhaps we are suffering with? And then we'll come to prevention later on.
Thank you, sir, for the opportunity actually to participate in this webinar. Very important webinar, particularly as you started that we have been living in Delhi, where we always suffering from so many issues, and on the top of that there is a pollution. And definitely when you talk about the pollution, as you have very rightly said, it is not the current problem, but we are dealing it with ages. So as a microbiologist, we have seen that how the number of patients are increased, particularly in the winter, and also in the season when there are pollens. So in our experience, actually a large number of patients of COPD or asthma or various chronic pulmonary disease are coming to the hospital and then being sent to the lab for diagnosis. And where with our clinician friends, actually we talk and we wanted to find that what are the remedies and what is the diagnosis, how frequent which sample is to be taken, and how it can be managed, because we know that once it is the COPD, the frequent exacerbation are there. So time and again, various samples are being sent, and we timely have to diagnose, and rapid diagnosis has to be made, and then the treatment should be given. And nowadays, which when we talk about the healthy lung, actually, so nowadays we are talking about the microbiota. Basically, we talk about the lung microbiota, but also nowadays there is the evidence is that the lungs also have is a home for microbiome, which are various microbiota are housed. and it is the basically balance of or equilibrium of that microbial community, which is the neutral community, and if there are disturbances in that microbiome, it causes dysbiosis, and that is the root cause for various I'll say hindrance of managing the pulmonary hypertension. We'll talk about later how that happens. Thank you, sir.
Thank you, Dr. Sherwal. We'll come back to you again, and before my next question will be with Dr. V.P. Gupta. Dr. V.P. Gupta is a very close friend, colleague, associate of mine, and we have been working together in Delhi. Incidentally, I am president of Delhi Council of Physiotherapy and Occupational Therapy, and he is one person who started this concept long back with his entire group. And he had been the chief of All India Institute as regard the respiratory physiotherapeutic center is concerned, and he has contributed a lot in the new CNS center, which was started long back. And then thereafter, after retirement, he is with Escorts as chief manager, as well as because of his dedication, he is also the expert member. You must have heard that now Government of India has started National Commission of the Allied Health Group experts, and he is one of the expert member as regard physiotherapy is concerned. So your presence, Dr. V.P. Gupta, is very important to us. What had been your experience during your aims and of course after aims from your angle as regard to pulmonary rehab is concerned?
Sir, good morning. Very good morning to all my colleagues, all my seniors. This has been a great opportunity to join with you on this webinar, which is of very much importance in present circumstances. Because one, as my senior colleagues told, Dr. Mehta, Dr. Vinny, Dr. Sherwal, that pollution, you yourself have described pollution as a major cause in metro cities, not only in metro cities, but in even tier 2 cities also, where the number of vehicles have increased, industrialization has increased, the mechanization has increased. So along with the pollution, I think the sedentary lifestyle is one cause, another cause, adding to the pollution, which is causing pulmonary disease on the rise. We are living in a closed structure, right? All in like all houses, all offices, all environment. Our working environment is totally claustrophobic to some extent, and they are all governed by artificial ventilation. So our like air conditioning, our change of temperature from air condition to the normal temperature, and the heat governed by the air conditioning which has been released in the atmosphere, the loss of humidity, and our sedentary lifestyle. These are some factors also, sir, which are contributing to the pulmonary diseases also. Because our sedentary lifestyle has been a cause. Since I have been in AIMS, I have been seeing the cardiac disease patients who have been operated. I was in CTVS. I joined CTVS from the very beginning and have been remaining in CTVS. Sometimes in community rehab, because the follow-up patients we have been dealing with, some camps also we have been dealing with, some facilities in outskirts we have started with. So in community, we have seen after the disease pattern, the people are still not aware of what corrective measures they have to take. So education is very important regarding the prevention and how to alleviate the effects of our sedentary lifestyle. So these two things have become very important, sir. And because the myocardial load, which has been increasing in heart patients because of the comorbidities, as well as because of pollution, as well as because they are forced sedentary lifestyle, the restrictive lifestyle. So this vicious cycle has left us in a chamber of pulmonary diseases. Our deconditioning, our muscle loss, and our oxygen increase in our oxygen requirement is leading to pulmonary diseases in most of the cases, sir. Over to you, sir.
Thank you. Thank you, Dr. B.P. Gupta. Now I am coming to Dr. Sudhir. Dr. Sudhir is our colleague as a pulmonary medicine expert, and is working for Kailash Hospital in Noida, a very senior colleague of ours. Sudhir, can you hear me?
Yes, sir, I can hear you.
Great. What had been your experience in last 20 years that gradually you find that due to change, I mean, pollution is one of the factors, but what do you think are the other factors which are perhaps leading to poor quality of the lung health?
As enumerated by my colleagues,
And my second question is, what happened after COVID?
so there are few pointers, as already enumerated by our senior colleagues. Pollution is one of the major cause of this thing, and second is increasing incidence of smoking. Smoking again causes poor lung health linked to bronchitis, COPD. And on the top of it, if we look into it, honestly, that's the incomplete understanding of the lung diseases and their treatment. As I see many patients are afraid of telling the patient, you're suffering from asthma, you are suffering from bronchitis, or you are suffering from COPD, which are lifelong diseases and need lifelong management. So they are poorly treated patients who again lead to decline in their lung functions and deterioration in lung health. So it should be taken care of. And it's not only pollution. After COVID, of course, as you told, that COVID has been a major contributor of poor lung health. So many patients, I think almost everybody has suffered from COVID. There may be few persons who have not suffered from COVID. They've taken a lot of toll on these patients. Those who suffered from severe COVID, they had a CT score of 24, maybe 20, 15. They had a lot of fibrosis and the end stage lung. Many patients are coming with post-COVID ILDs also, and post-COVID COPDs, have newly diagnosed asthmas. So all these factors, they are leading to increasing health burden of lung diseases.
Thank you. Thank you, Sudhir. After having interaction with all my experts, now the question is, which comes to my mind, and Dr. Ravinder, can you
Yes,
hear
sir.
me? Can you tell us the various components? If I want to establish a good pulmonary rehab center within my hospital or within a standalone pulmonary rehab center, so what important pillars you would like to say? It's a good
Sir,
clinician or
first of all, adding.
physiotherapy. Yeah.
Yes, sir. Am I audible, sir?
Yes, yes.
Yes, sir. So to add to the last points which my eminent colleague said, in COVID was the eye-opener that pulmonary rehab turned out to be a change for COVID recovery. So that was the thing which countries in the world who had a mature pulmonary rehab did much better for their patients and their survivors than countries who did not have an organized system of pulmonary rehab. Am I audible, sir?
Yes, yes, you're audible.
Yeah. So just a comment. It always leaves a little sadness in your mind because, as you pointed out, you pointed out a very interesting term, public health issue of great importance. So that's something to just keep in mind and highlight, so that we know the importance of keeping preparation ready, especially when pandemics come unannounced. So that's one thing. The second is your question on how to create a pulmonary rehab program. Yes, it is indeed challenging. And as you yourself very adroitly pointed out, it is a question of where you're going to do it. Are you going to do it in a hospital setting? Are you doing it in outpatient setting? Totally, where there's a standalone place or where only clinics are there? These are all very important things. So from that point of view, if we see like the patient setting much more. Hospitals are prohibitive. A lot of these patients are post-hospitalization, don't want to come in. They get concern, fear, and anxiety, which is a part also of pulmonary rehab management. So in such a situation, it is either a best a standalone area or a little away or an outpatient area, I think, which serves the best interest. Indeed, a statement easy to make in our country, but very difficult to implement because most of the time rehab gets pushed into other rehabs, ortho, neuro, general, and so on, which I don't think goes a long way in executing our product. The second is how to do it would be the three usual things. Basically, it is how to get patients in, information, access, knowledge, education, and all the tenets of how people are attracted to a product which is meaningful to them. The second is appropriate infrastructure, which means a nice wide area, all the right equipment which is required to make sure the product is well delivered. And that's a full range, right, from simple regular stuff to technology. And that's a different, longer discussion. And the third part of it is the most important is human resources. A passionate leader in the rehab space. Most of these are masters in cardiopulmonary rehab and who can lead the whole team and at the same time make sure that the systems, processes, and the flow is good. Last but not the least is integrative aspects where they come back to the clinician. So for the patient, it's on the left side is the clinician, the right side is rehab. So there's a crosstalk between the two to enhance communication, and it goes a long way in trying to establish a more effective rehab program. So these are the four tenets which have to be then broken down into bits and pieces so as to make an effective and high-class rehab program. Over to you, sir.
Thank you. Thank you, Ravind. I think so. Pulmonary rehab, it itself is I like to call it super specialty. One question comes to my mind. That is, in olden days, Dr. Vinay, you remember in olden days when we were treating pulmonary tuberculosis, the sanatorium approach was strongly recommended. When we were children, I remember that sanatorium in different places. What was the basic concept of sanatorium that time?
The
Would
basic
like to
concept,
comment?
yeah.
Yes.
So am I audible?
Yes, yes.
So the basic concept of sanatorium was saaf hawa, saaf pani, and the adequate nutrition, which was an issue that time
So
because we
the
were
good air, good water, and good
nutrition.
food, and exercises.
Exercise concept, I think at that point in time had not penetrated deep down because that time the concept of rest and having adequate amount of days where you are resting most of the time was more in vogue. So it was more to do with the nutrition, which was very, very hampered in especially patients with tuberculosis. Because that time we were actually under the influence of the Britishers. We had not come out of the clutches of the British population, and our resources were obviously hampered. So the main area of focus when your money is an issue is your nutrition, khana. How would you be able to arrange the adequate amount of food, which is a necessity in case of tuberculosis to get better, because it is on not only the chemotherapy which is important, it is the nutrition all the more which is most important. So sanatoria basically advocated that these patients should be taken along with the isolation which they require away from the people, so that they are not disseminating the disease anymore. They should be kept in an area which is very well ventilated. The concept of ventilation comes in because the air changes are important in case of the spread of the diseases which spread by droplet infection. So these areas were very well ventilated. The air changes would happen many number of times, which is 12 to 15 per hour. And then they were close to villages where the air what was considered better, the water quality was better. and these centers were provided with more amount of funds for nutrition, wherein at least high protein diet was advocated. So that was the basic concept of sanatoria, which focused on the nutrition of a patient to get out of the clutches of tuberculosis. Now, at that point in time, they were so debilitated that they were not able to engage in any kind of physical activity. Vis-a-vis, when we compare this to the current age, where excess of everything is also a problem. So if we consider what is important in current times, which is leading to so much of hyperreactive airway, especially the post-COVID era, the problem is that the single word which comes to my mind is inflammation. So this inflammation is also propagated by the obesity which has set in, the excess of junk food which is there. It also leads to excessive amount of inflammation in the airway, which makes you prone to viral infections and every other bacterial infection. So if we consider the current era, the nutrition is not an issue anymore in most of the households across India, but the other problems are.
Thank you, Vinu. This was the question in my mind, sanatorium approach. And while you have clarified, the original sanatorium during British regime was perhaps the basic cause was uh, isolation, good air, good water, good food, nutrition, and somehow that from social angle it became a stigma also that so and so has gone to sanatorium, right? And luckily that concept is no more there in our society, and I'm very happy to know that. So coming back to Dr. Sherwal, in Government of India, we have many, you have been the part of DGHS, and there are many programs as regard the NCDs are concerned with blood pressure, diabetes. But do we have a good program for pulmonary health?
Basically, there is the program basically nowadays purely not pulmonary health, but basically because tuberculosis unit is there. So RNTCP has been there now, tuberculosis elimination program is there.
That is
So
there, tuberculosis, but beside
yeah.
tuberculosis.
As far as pulmonary rehabilitation, I don't recollect there is any independent
That's
program.
why.
So that is an issue, I think. But now I'm discussing with you. This is one area when we are living in Delhi, particularly, and we are talking about various infections, inflammation, and the pollution. I think we need because as we have worked in the COVID, and we have seen that how the patients have suffered. So I think, and you might have seen after the COVID, actually, there are so many patients are coming with the symptoms which are usually sometimes are not related to the chest infections. So like brain fog or tiredness or for that matter GIT symptoms or sleep symptom. So there are various symptoms which and we started the long COVID clinic in Rajiv Gandhi Super Specialty Hospital. We were the first in
Yes,
uh,
yes.
yeah. And we have seen, I think, more than 500 patients which have come, for various reasons, and including the psychiatric problem which patients were suffering. So I think it is one of the area we need to emphasize that pulmonary health is important when we are talking about individually of the tuberculosis, and government is working on that. As you know that we are going to eliminate tuberculosis as this year is as our honorable prime minister dream. However, it is not possible very soon, but as the government is working, I think one day we'll be free of the diarrhea disease, tuberculosis, and then these other chronic lung disease are, I think, will be got the attention, and then we should basically bring out some program where we can talk about the nowadays the government of India has already started, I think, brain health, and now there is a time to include, a program on the lung health also.
Lung health. I think like we have started talking about the bone health or knee health, or I mean the focused area. Lung health should be the focus of Government of India as a policy, and my our colleague in front of me will agree that lot of co-consideration. Dr. VP, can you hear me?
Yes, sir.
Now, since you have had it, besides, I strongly feel that physiotherapeutic intervention plays a very, very important role, right? So,
Yes, sir.
number one, what are your views that once there is patient is suffering which requires physiotherapeutic intervention in non-ICU scenario, and then in ICU scenario, and then as a preventive aspect. इन तीनों के बारे में आप कमेंट.
Sir, since I have a long duration with my CTVS department since
Yes.
my starting of my career, so we had started a pre-operative clinic, sir, pre-operative conditioning clinic, which was with the aim that the people with the cardiac disease or the congenital disease who were elected to be operated, electively selected to be operated, they should have a proper lung health before the surgery is undertaken. So that was a preventive health clinic for in morbidity. We used to take their pulmonary functions. We used to enhance their pulmonary functions through postural drainages, through various physiotherapeutic interventions, and it was my findings, sir. We still have the data, but unfortunately we could not publish it, though we tried it so many times. But the data, because of the change in computer system, the data was partially lost, and we still have the data of about 3,000 patients who have been given pre-operative pulmonary physiotherapy, and their lung functions was improved from FEV1 50 to 56% to 80%. So those kind of education is required, and those kind of facilities are to be required in all setups. And in community physiotherapy, sir, we used to have the people who were referred to us with pulmonary dysfunctions like respiratory dysfunctions, shortness of breath, and COPD patients. Dr. Guleria used to refer me, and these kind of patients were given preventive as well as curative therapeutic interventions, and there were a lot of improvement in those areas. But unfortunately, in cardiopulmonary setup, even in AIMS, we could develop this pulmonary rehab program only after the advent of pulmonary department, pulmonary medicine and sleep medicine department. So we have a small unit as a pulmonary rehab over there, and their preventive physiotherapeutic interventions and therapeutic interventions both are being undertaken for our patients. Though we do not have our isolated tuberculosis unit, but we have very good pulmonary isolation unit where some of the TB patients who have been intubated or who have been recouping from pulmonary TB and or the MDR TB. So these people are placed there, and the physiotherapeutic interventions are regularly there. So with that, the pulmonary toileting, airway maintenance, airway clearance, recruitment of the lung units, and oxygenation, proper oxygenation, oxygen therapy, as well as the conditioning exercises, which were useful in those patients. So we have a small unit, but cardiopulmonary department does not have any facility, or we have a very small unit of our physiotherapy department in cardiac setup. So there we used to take exercise testing, regular exercise testing after 3 weeks or 6 weeks we were doing. But now this has also been a rare commodity now, because that setup has been reduced down in space. So these things are definitely beneficial. And in post-operative patients, when the patients were ventilated for a long time, chronic disease, chronic pulmonary dysfunctions because of the cardiac post-operative complications, or post-operative pulmonary complications. Lot of like chylothoraxis we have treated, lot of hydropneumothoraxis we have treated, and there the recruitment of lung and postural drainage were the crux of the treatment part. Besides medication, their mobilization, their recruitment of lung units, and increase in oxygenation. So how to we were able to wean off the oxygen in a shortest period of time in these patients. That was the basic outcome of our treatment.
Thank you, Dr. Vishwa. Coming back to Dr. Sudhir. Sudhir, can you hear me?
Yes, sir, I can hear you.
Okay. Now, I'd like to continue the same question with you, that in our ICU scenario, when critical care patients are there requiring good care as regards the lungs are concerned, because perhaps this is the most important part besides the basic pathology being treated, whatever it is. And we are having a good team everywhere. But this question to all my expert in front of me who are part of critical care, do you think in your setup, are you satisfied with type of respiratory exercises and the time devoted on the patient is being undertaken?
In ICU setup, there are few demands of the patients which are different from normal patients. In ICU patients, patients are very sick. Usually, they are not able to cup themselves. They are not able to take out the secretions, and due to respiratory conditions and other illnesses, there are a lot of secretion formation is there, and leads to pooling of secretions, especially in neurological patients. They are not able to cough. They have a poor laryngeal reflexes. In sick patients, they are moribund. Some patients are on ventilator. So we need a lot of coordination between different teams to help them in assisting with the lung function, proper lung function. So here our physiotherapy team comes into picture. They take care of the patients very well, and they do for assisted coughs as well as vibrations and posture changes. At the same time, we do give some medicine mucolytic agents and change in posture leading to increased mucus extraction and help the patient in cupping out the mucus and the secretion from the lungs. But this is not a job of one department only. Let's say there is a physiotherapist, but again, they have a limited time with the patient. The efforts of ICU team, the nursing care, nursing staff also come into picture. At the same time, it's the efforts of the ICU consultants and ICU team which comes into picture, which see that which part of lung is more affected and in position has to be maintained. Sometimes right, left up, right up, left up, or sometimes patient has to be gone for continuous physiotherapy and continuous assisted cuffs. And this has to be done by ICU staff as well to be learned by ICU doctors. It's not only a physiotherapy team which will manage it, it's a team effort.
Agreed. It's a team approach. Then Dr. Vinu, do you think in any setup, the team approach, the nursing, mainly I am concentrating on nursing help, are they well trained to help you?
Well, sir, I would say that I am very, very lucky to work in a setup where the nurses have been really attuned to working in such environments where they are able to mobilize the sick of the sickest patients of mine, because early mobilization in ICU, we have very, very robust data now that if we mobilize patients who are on ventilator as well, of course, when they are off sedation, the outcomes become better. So our staff is very, very attuned, and they are told this from day one that mobilization has to be incorporated into the protocols of the ICU. In addition to that, small little things which are absolutely important for the clinicians and the people who stay with the patient bedside in the ICU is early sedation holiday, which is something which we forget. So even if you are stopping the sedation and patient is able to move their hands, their feet, their arms, it is most of the number of times very sufficient. If you're concerned that your patient is going to take out their tubes and their gadgets which are in and around the patient, then a guarded restraint of the patient might be required, which we do at our center after adequate consenting from the family members. So I'm very lucky to have a setup where multidisciplinary care and the training of the personnel is undertaken from time to time. But yes, I do agree, manpower is an issue. It is not only the training of the manpower, but the number of people which are required in such processes. For example, in severe ARDS, when we are proning a patient, you at least require 5 to 6 people bedside, including nurses, the physiotherapist, the doctor at the head end who's holding the tube of the patient, and the housekeeping personnel. So yes, if we compare our people to the Western world, our manpower is better. And if there are any gaps, considering the training of the personnel, that can be very well undertaken. So I'm very much interested in this arena of early mobilization, sedation holiday, how we can take care of patients in the ICU and advocate more amount of physiotherapists coming in and helping out the patients. So very important topic again, but again, the penetration into the smaller centers needs to be done.
I'm not talking of any specific hospital, but I'm talking Pan India. What I feel and observe that our hospitals are very major in engaging the services of physiotherapists, which they should engage more often and for longer duration and expertise. That is my observation. Ravinder, your comment on this?
Yes, sir.
Pan India.
I totally agree, sir. I think it's a it's extremely important, highly underrated, under resource allocated, underpaid, and underemphasized fields. I think we really need to look at it very carefully. Unfortunately, medicine is carried by economics. Wherever there has been money, cardiology, orthopedics, neurosurgery, robotics, all these areas, emphasis has come. But this has not been. The thing is, you have to nurture people who are passionate about their work. There's so much attrition in this field. Understanding is low. The importance of what they do is not told to them. We are not even sure of the training, how they get exposed in the physiotherapy colleges. And so there's a whole full 360-degree turn which needs to happen. And I think your webinar and your topic, commend you on choosing this, is a step in trying to actually increase awareness and address all these issues. I mean, ultimately, the journey of 1,000 miles has to begin with a single step.
Thank you. Thank you, Ravi. I think what I gather from all the discussion, that our pulmonary health is very important. Its prevention aspect means you have to take all preventive measures so that it doesn't get affected so easily, though all the provocative factors are there with us in our surroundings. But if in case my air is polluted, it is polluted. Let the government do its job in perhaps reducing the pollution. But Dr. Vinay, if we have to live, we have to live. Then what to do? You have to give a message to yourself. You have to give a message to the public कि जब हमारा pollution है उसके लिए क्या precaution करें so that our lungs remain on the healthier side. And this pulmonary rehab is one of the steps which we have to, of course, there are many things which I am going to take up. Tiwari ji, abhi thoda time hai?
Yes, sir, you go ahead.
Thank you. Then comes the...
Sir,
Yes, please.
I'm sorry, actually, as usual, actually, microbiologists remain behind the stumps, actually.
Of course not, my dear. तुम यदि जादू कर दो तो सब कुछ खत्म हो जाए.
Basically, because when talking about the ICUs and rehab setting, actually, and you have rightly said without microbiologists, the core team is not complete. So
Yeah.
I'll say that when we talk about the clinicians, the anesthesia, or for that matter, the nurses, physiotherapist, and dietitian or the paramedics also are very, very important. And the microbiologists, not in the forefront, but they are behind the scene, but they are important pillar for this. When the patients are in ICU, please remember us. Otherwise, we usually come and do the sudden what we say, that Inspector Raj. So because usually we need to know when we are in ICU, there are setup, there are shared equipment, close conducts are there, and patients are vulnerable. So prevention of infection prevention is very, very important. So when we talk about the training, actually, that one training which all ICU people, including the doctor and the Safai Karmachari, need to undergo is the basically infection control program, which microbiologists are really fond of, and plus they really want that our clinician friend, our paramedic staff, and the patients are safe. So whenever we are running any setup, whether it is ICU or rehab center, so infection control is very, very important. During that, we do the surveillance, or there may be some outbreak, or we need to train the staff, so that there is no untoward outbreak in the setting. And along with the clinician, we will be able to settle the patients, and they will be recovering, and we will be able to tell them how to manage. The antimicrobial program is there. So that is very, very important. And here I'll say that I have been, Dr. Sudhir, I might not be remembering, I have been his patient in his ICU way back, I think 4-5 years back. And I have seen their setup. They have taken me, my care so well. I'm really thankful to the team of Kailash. Wonderful, management. So, as Dr. Agarwal has said, that pan India, there should be ICUs where the patients are there, which needs the pulmonary rehabilitation, and which our nursing care or physiotherapy friends are providing at times, which are very, very useful. And particularly when Dr. Gupta just said, maybe just changing the posture, or maybe massaging, or maybe minor exercises, so which are really, really very good. Thank you. I'm sorry I barged in.
Oh, no, no, no. I think as an experienced administrator, you have given a very important comment, right? So my last part of discussion will be integrative medicine. Now I want to say, what is the status of yogic science, right? Yogic science is not only yoga, it is the science behind it. Dr. Vinu, आप स्माइल कर रही है कुछ सोच के. So we have been talking about yoga is our strength, and other integrative interventions are our strength, right? So in totality, can we think about incorporating our Ayush system into pulmonary rehab? I would like to start from Winnie.
Very well taken up topic, sir. So sometimes it is considered that those people who think about Ayurveda or yogic sciences are into a regressive thought process or something. But since I practice yoga myself, so I have seen a transformation happening in exactly 2 years. So considering the amount of pollution which we are living in, one of the ways how you can improve your lung health is through yoga, which not only enhances your physical transformation journey, but also your mental health effects, which are immense considering the process of yoga. So the the incorporation of preventive health sciences into your pulmonary rehabilitation programs, which are particularly for chronic respiratory health issues, this can be very well undertaken, at least to start with as a pilot project in bigger cities where people who come to you and they tell you, look, we have been smoking for many number of years, what we can do to get rid of the smoking as well as improve our lung health. So these sciences in the form of preventive health enhancement can be taken up into the pulmonary rehabilitation programs where we already have the space and equipment which has been earmarked for pulmonary rehabilitation. In addition, if we particularly talk about allergic health conditions related to the lung and the ENT area, I feel it is very, very important that we teach our patients that how important it is to keep your nasal area clean, and the processes of jalniti, which are actually ignored by many of us, have immense power in terms of curing the allergic conditions, which can be very well taken up from the Ayush health sciences and incorporated into the allopathic system of medicine. So I always tell my patients who have allergic health conditions to incorporate Jalniti and these processes into the system, because chronic health conditions and preventive health system is very well elaborated in our Ayush system of medicine, which should be incorporated in our system, which is what I feel.
Thank you, Vinay. Ravi?
Yes, sir. Can you hear me?
Yes.
Uh,
Welcome.
so, so to add to your point and Vinny's, excellent expansion, I think the whole issue here is that there is regular science which the West espouses, where you do trials and you prove that certain interventions have a certain advantage and you implement it. And that's how pulmonary rehab has been expanded further. And then there is the other way of making India or expanding it or giving it more flavor based on tools which are not assessed by Western science, which is our science of Ayush. I have only one word of caution. I think we have to make it, the word integrative we used is worth $1 billion over there. Because if you integrate it, you have to make sure the practices are standard. The practices are, if not studied, at least studied in a way that they can add to it. And, if this webinar happens 5 years from now, you're actually dealing with data points. And those are used to also augment the science of the Western world, because currently they are holding the reins of science. So that we can not only say this is ours, but this is ours with data, which can be really used to enhance the product. The second thing is that usually in any product, if it's a procedure or a medication, then conventional science is at loggerheads with other sciences. But in an area like rehab, where it is a conglomeration in the beginning only of multidisciplinary agendas, there are no medications to talk about. Anything which can be integrated of use, whether it is yoga or Ayush and so on, indeed with the right structure, study, utility, and put into a algorithm, can be very useful. So a lot of promise, but needs to go through the rigor of science also, I think. Over to you, sir.
Yes, I agree that we keep doing promises, but actual implementation, I think it has to go. Some of us has to raise our voice. That too often and often, right? By raising it once will not help. Dr. Gupta,
Sir.
Vishwa, your opinion about integrative, of course, I agree with Ravi in that regard. The medicines are concerned, we have to be very careful that all those medicines which we are using cannot be used unless they are taken as a fully certified and well-tried part of the pharmacopoeia. I fully agree. But rest of the thing, what is your opinion as physiotherapist? Vishwa?
Sir, am I audible?
Yes.
Am I audible, sir?
Yes.
Yes, yes.
Sir, that was a very relevant question, sir, and Dr. Vinny has already explained. I had been in charge of a Center for Integrated Medicine in AIIMS when it was established since 2016. From 2016 till 21, I was in charge of that center, and we had undertaken around 32 projects for integrating all the systems of medicine along with allopathic system of medicine. And we have published few papers also. In cardiac sciences, for cardiac patients, we have published 2 papers, which proves the conclusion was that the patients was immensely benefited. The significance level were very high for that. And the integration of yoga as a prevention for the patients who have been on ventilator for a longer time and who have been sedentary post-operatively. For those patients, integration of yogic exercises and physiotherapeutic interventions, therapeutic specific exercises have been of immense help. So preventing preventing the community from pulmonary diseases, as you had raised a very valid question, can be through our body immunity, which has been enriched through the activities, various yogic activities, various therapeutic activities, and the stress, non-stress environment. So because stress is also taking toll to our people, stress because of the lifestyle, stress because of their occupation, stress because of their home issues, the nuclear families, all these stresses are also causing the concern of for the health. So in integrated center of medicine, sir, we had developed the facilities for the in telemedicine also, so that we can contact the people from far ahead. The people who have not been able to attend the clinics regularly can follow up the treatment part for a longer time. So that way we can involve more number of people either from the community or from the as a patient population. So as a preventive part, we can utilize those facilities for better prevention, sir.
Thank you. I think, Vishwa, this concept of pulmonary rehab is not only within hospital, it has to go to community.
Yes, sir.
The same way cardiac health. I think a person of my age or even of your age should be fully trained as regard cardiac rehab is concerned. We must
Very
know
true, sir.
how I can keep my heart healthy, how I can keep my lung healthy.
Healthy.
So these are the very important messages. I think uh, quickly, Dr. Sherwal, 1 minute message from your side.
As far as microbiology is concerned, I think we are adding for the care of the rehabilitation for the patients. There are now talk about the prebiotics and prebiotics. There are talk about the immunotherapies, and now even microbiome personalized therapies are being worked out so that patients can be taken care in a better way in the future. And AI or automations are coming like anything, and I'm quite hopeful that in future AI even may have some role for managing the patient in the rehab center. So as the other speaker has said, when we talk about yoga or any preventive measure, I think they are very good initiative. And yoga, of course, for healthy or for disease, depending on how much he can start, how much he can perform, and how much he can sustain for longer period. I think it is very good. I
ये
think
तो
we should.
आपको पता है कितनी लगन उसके ऊपर कर देते हो ना.
Thank you, sir. Definitely.
So, Vinny, your 1 minute message.
So my 1 minute message would be that pulmonary rehabilitation and lung health needs to penetrate deep down into the tier 2 cities. It is much more concentrated at the moment to few centers. So it is not only education of general public, but also healthcare professional, which needs to be incorporated on a multidisciplinary level, because it's not only respiratory physicians who need to be educated. It is the cardiac, our general physicians, the internists, our cross referral systems, the surgeons which need to be told the importance of respiratory rehabilitation, because most of the times complications do also happen in post-operative patients. They get atelectasis followed by pneumonia and whatnot. So multidisciplinary education, as well as education of general public, as well as the betterment of training systems which has to happen, of course, at the government level, which has to be there, which needs to be incorporated.
Thank you. Ravi, your 1 minute message.
Sir, I think we need to basically now make sure that rehab reaches mainstream, integrative, contemporary medicine for all the right reasons. Patients also need to realize that procedures and medications is not health. Rehab is an integral part of it, and lungs have come to super center stage after COVID, which needs to be reinforced. The second brief thing is that we have to now make a clarion call in medicine that economics should not guide resources. It is also the importance and value of a product which should guide, and that's where policymakers, hospital administrators, and all need to wake up and see that there has to be certain budgets, just like the government used to say, take this land and do free medicine. There has to be budgets for all this so that we have meaningful medicine and not just economic-based medicine. Over to you, sir.
Thank you. Dr. Sudhir, your 1 minute message.
So as a pulmonary rehabilitation is concerned, it's multidisciplinary and multimodal approach.
Thanks.
Multidisciplinary, there are many stakeholders from physiotherapists to clinicians to nursing staffs to attending physicians to the patients to their family members and the peripheral treating many healthcare workers. It has to be integrated and everybody should be educated enough and everybody should be understanding enough about the lung health. It's not only cardiac health. And at the same time, it's a multimodal approach. You can see many propaganda which say Ayurvedic is better, allopathic is better, to stop this medicine, we will to do this thing and it will stop all the medicines. One has to remember that all these are for the benefit of each other. Every system has its own pros and cons. We must understand the pros as well as cons, as well as Ayurvedic, as yoga, allopathy medicines, Ayush medicines. Everything has got its indication and contraindications that has to be seen in conjunction with each other to get maximum benefit for the patient who is our end user. And as far as the lung health in elderly is concerned, they are often suffering from cardiac health also. One should remember that it's not only cardiac health or lung health. It's a cardiopulmonary apparatus which comes into picture. Heart and lungs, they both work in conjunction in tandem. So nowadays, it's a recognized thing that it's a cardiopulmonary apparatus rather than only cardiac apparatus or only the lung apparatus. So that should be taken care of and that should be understood. Thank you, sir.
Thank you, Sudhir. So far, we have been discussing pulmonary rehab and cardiac rehab. Now we will call it cardiopulmonary rehab efforts.
Okay.
Dr. VP, your last 1 minute comment.
Sir, the discussion has been very fruitful, and I would say that the proper development of infrastructure, proper education amongst the patients, amongst the healthcare workers, and among the attendants, the general public, and availability of the infrastructure and manpower. These three components have to be there for an effective preventive program regarding the cardiopulmonary health, because our workload is increasing, our stress factors are increasing, our family supports are decreasing, and the pollution, of course, is taking its toll. So we have to learn how to live in such a kind of atmosphere in a healthy way.
Thank you. I think let me, in 2 minutes, try to summarize that there is no doubt that the concept of pulmonary rehab or pulmonary cardiac rehab. In fact, we were thinking of taking cardiac rehab in our next webinar topic. Tiwari ji, please,
Yes, sir.
can we note it that we will also take up cardiac rehab. But I agree with Sudhir, this cardiopulmonary is an interlinked subject which has to be dealt together. This is number
Yes,
one.
sir.
And as regard community is concerned, all over India, I'm not talking of few tertiary care hospitals within A-grade cities of India, is not India at all. It is one part of India, but we are treating each and every corner, geographical corner, whether it is in north of Uttarakhand or in northeast area or in anywhere. We have to perhaps look into the pulmonary rehab in totality, which is feasible. And partially, we all are doing it. It is important for us to come out with something. So this is one attempt. I am going to request Tiwari ji, who is the all in all of Double Helical magazine, that now he comes out with a magazine with one dedicated topic. If comfortable, Tiwari ji, you should come out with your, whenever it is possible, one
Well,
entire issue on pulmonary rehab.
yes, why not?
And you're lucky that all the experts are in front of you. Of course,
So,
few more can be
with
added.
your permission, should I raise some question? That's
Yes,
I got
please.
some.
This is my simple message. And now I hand it over to, and before that, I'd like to say thanks to all my colleagues
Thank you, sir.
who have
Okay,
participated.
thank you very much, sir.
Thank
Now,
you.
I
That
would
too
like
on
to know.
Sunday, it is absolutely not desirable to trouble you on Sunday, but what to do? Somehow we try to make it, but this time, most of the time we are doing it on Sunday only. Yeah? So maybe that we'll request you again sometime to come back to us on this platform. And my sincere thanks to all of you. Back to
Thank
Tiwari.
you, sir.
Thank you, sir.
It's a pleasure to see you early morning on Sunday.
Sir,
Thank you, sir.
Tiwari.
sir, please stay with us. I have few questions.
We all are with you, my dear.
Sir, this question goes to Dr. Ravinder Mehta. He is expert in the respiratory capacity. Sir, are you listening me, sir? The
Very
first
much,
question.
Tiwari ji, very much.
Yes, sir. Could you say each pulmonary rehabilitation only for people with chronic condition like COPD, or can it help those recovering from COVID-19 as well? What would you like to say?
Absolutely, Tiwari ji. COVID-19, as I spoke earlier in the discussion, was a major reason for debility and an entity called long COVID, which we had never seen before. So pulmonary rehab actually done in the right way was a game changer for these people. Because just like COVID, there was no medication. When you don't have medication, you have to look, widen your horizons and look carefully. And that is why programs with PR, pulmonary rehab for them actually made a very big difference in trying to get a large population of people afflicted with a long-standing malady to get them back on their feet.
And one more, please, sir. What would you say? How long does a typical pulmonary rehabilitation program last, and when can one start noticing improvement in the breathing and stamina? What do you say?
Excellent question, Tiwari. So there's data on all this. So by and large, pulmonary rehab is a supervised program where people come anywhere from 2 to 3 times a week for 12 to 36 sessions. So it will last anywhere from 1.5 2 months all the way till 3 months. And besides those 3 days where they do it supervised, the remaining days, barring maybe one day, they're supposed to do it in home and increase the learning curve. There are two aims. One is the initial supervised improvement, which happens in a person who is at need. And the second is to change their mindset and behavior patterns so they see the importance of all this and continue. So in terms of data, we saw in our center, we finished around 7,000 rehab sessions in the last 1.5 years, is that 6 sessions is the earliest to notice a difference. And that's when they become bound to the program. They have a buy-in because they see a difference and it continues to upskill. And 12 to 36 sessions is the time when they see maximal benefit. And then, of course, if they continue, there's a maintenance program which I talked about. Over to you.
Thank you, sir. Thank you. But we are very unlucky. We are not able to watch on your video.
I'm sorry, sir. As I mentioned, travel from that national meeting beneath there also.
No, sir. No, sir. Thank you, sir. Next question goes to Dr. Bini Kantru. Dr. Binny, could you tell us, are there any risks or side effects associated with pulmonary rehabilitation exercises, especially for elderly patients with multiple health issues? What would you like to say?
That's a very good question, sir. So, considering these people are very, very debilitated in the sense that their nutrition is also affected, their bone health is affected, the muscles are not as strong. There are some risks involved, which includes the risk of falling. However, considering these centers are well equipped with the equipment which have the internal mechanisms of prevention of falls, as well as supervised training programs wherein a person is supervising you for your own strength and giving you graded forms of exercises. So falling is something which needs to be considered when you are giving the caregivers instructions for pulmonary rehabilitation at their own home. In addition, we have certain tele-rehabilitation centers which are doing the work of rehabilitation online. So the house of the person who is concerned, who's undergoing the pulmonary rehabilitation, has to be assessed at least through telephonically through a video call, so that you are able to gauge the amount of risky environment the patient may be living in, so that the slippery floors and mats are taken care of, their equipment which is lying there, which is seen adequately, the bed height is seen adequately, the chair height is seen adequately. If there are any corners which need to be taken care of, if they unfortunately have a fall, they do not injure their head. So these are some of the risks which are involved with pulmonary rehabilitation. But having said that, a meeting with your clinician to assess your level of strength and your readiness to undergo these programs is paramount. So always go to your primary healthcare physician, who's taking care of you for years together, who knows you inside and out, can give you an insight of the risks which are involved, particularly as in your case.
Thank you. As you said, telephonic media, could you tell us, with telephonic medicine gaining popularity, and can pulmonary rehab can be conducted effectively in an online format? What do you say?
Definitely, sir. During the COVID times, we at our own center also had the privilege of doing it, the program online, because that time the patients were not willing also to come to the hospital area. So we have had a study where we did the pulmonary rehabilitation along with our physiotherapy colleagues for about 100 patients, and we had very, very good results. And the biggest the importance and biggest advantage here is that you can teach the caregivers who are intelligent enough to understand the exercises and the amount of time which they need to spend with their patients. If they can understand it very well, you can teach them so that they are able to take care of their parents or their patients at home. So that is one of the added advantages of tele rehabilitation. The other one is, of course, economically it becomes less taxing, because the transport and or everything is taken care of. The third thing is it could be merged along with the physical rehabilitation centers. So some of the sessions could be carried out online, which is being done by many of the pharma companies at the moment. We have certain pharma companies which are undertaking these projects, wherein certain of the sessions are supervised, and some of them are in their physiotherapy centers. So integration of both telehealth as well as physical rehabilitation centers can also be undertaken very well.
Thank you very much. And this question goes to Dr. VP Gupta, sir. As you are expert pulmonary physiotherapist, could you tell us, sir, as a caregiver, how can I assist a family member going through pulmonary rehabilitation? Are these we should watch out for during home exercises? What do you say, sir?
Is it through the telemedicine or through the physical approach?
Physical sir.
Yeah.
Should I repeat, as a caregiver, how can I assist a family member going through pulmonary rehab? Are these things we should watch out for during home exercises?
Okay. So during pulmonary rehab, as Dr. Vinny has especially mentioned, that there are certain precautions which we have to undertake as a caregiver. And besides those, the patient's physical condition needs to be watched out. During the exercises, the graded exercises have to be given so that the patient doesn't go into the fatigue situation and the patient do not desaturate. The patient's physical vitals have to be checked before and after the giving the exercises, so that all comorbidities can be also be taken care of, like patients are hypertensive, patients are diabetic patients. So before and after the exercises, all the parameters have to be stabilized, and right time of exercise has to be established after talking to your physiotherapy clinicians or the specialist or your primary care physician, so that the exercise benefit can be the optimum.
Thank you very much. And this question goes to Dr. B.L. Serwal Sahab. Sir, could you tell us what policy changes would you recommend to the government to prioritize pulmonary health programs? Dr. Serwal Sahab?
Yes.
Yes, sir.
Yes, Mr. Tiwari, actually, as we have already discussed regarding the program which we are looking for, there are, as we to know that it is an integrated program, pulmonary rehab has to be get the attention, and definitely Government of India need to be, get I think approached for starting the program on the rehab or lung health, which can include all integrated program which we have discussed, so that along with the tuberculosis, the other disease like COPD, asthma, or other chronic lung disease could also get attention, and definitely rehab. Once the Government of India prioritize, then the patients who are suffering from these chronic lung disease will be noticed and will get the benefit, and of course time to time treatment and follow up will be easy, and we can have the live data of certain patients that can be very well programmed. So I think we need to talk and discuss with the Government of India that we need to have a separate program on the lung health that may be combined with the as discussed with the heart health. So or it may be independent program.
Thank you very much, sir. One question goes to Dr. Sanjay Gupta Sahab. Does a diet play a role in improving lung function, and are these specific foods recommended for pulmonary rehab patients? Dr. Sanjay Gupta, please.
Sudhir?
Sudhir Gupta, Dr. Sudhir Gupta, please.
Sir, sir, diet has a great role to play. As we know, there are many diets which have fats and carbohydrates and protein. They have different carbonate quotients and different energy coefficients. And I think those patients who are sick, those who don't have a muscle mass, they will benefit the high protein diets. So diets we cannot neglect. One has to be a right blend of proteins as well as fats and carbohydrates to achieve the optimal efficiency of respiratory muscles. So it has to be used in context with the individual. It has to be individualized for each patient. It cannot be a, you can say, it has to be tailor-made. With many patients are suffering from pulmonary diseases, many patients suffer from cardiac diseases, there are many patients are suffering from renal diseases, some have thyroid disorders. So diet has to be comprehensive plan and right blend of carbohydrates, the right blend of proteins and fats. It has to be there. It has to be dealt with the help of an expert dietitian who can blend all these things as per need of a patient. But as a respiratory patient, I would like to have a high proteins. But as a case of patient of nephrology, they may need to have a low proteins. So this has to be a right blend in consultation with the expert dietitian.
Thank you, thank you. Sir, next question to Dr. A.K. Agarwal Sahab. Sir, as you are expert in your field, one of my friend Vishal Dukal, he's already joined the webinar, and I
Hello,
sorry to
Vishal.
say he having a lot of asthmatic problems. since very long, and he just willing to know all of the expert. How could he get cured through this webinar, through the pulmonary rehabilitation, which I discussed in the Bihar? Could you all
mean
tell us one by one?
asthmatic problem?
Yeah, yeah.
Hey, Tiwari ji, please read out the question I have given you. I have sent you a question.
You can raise, no issue.
Acha, okay.
बताइए
Actually,
विशाल.
yes, Dr. Saab, actually, my question is ki the medication for asthma is almost lifelong. So, like whether it is nebulization, whether it is inhalers and all that. So, is there any way where we can, minimize the intake of these, medications to avoid repetitive doses? Because somehow I think these can also have some side effects. And apart from this, Dr. Saab, one more question is anti-flu vaccine, is it really a good remedy to reduce the incidence of asthma, or to curb it, or somehow control it, or it just it doesn't work?
Okay. I think Vinay, will you answer this question? Vinay?
I think she has left.
Okay. Ravi?
Yes, sir. There's some poor connectivity, but I'll just try and quickly answer that.
Vishalji has raised a question regarding the medicines being taken for asthmatic conditions.
Yeah.
How you can reduce its intake, and can it be minimized or can it be totally finished?
Can you hear me, sir? Am I audible?
Yes.
Yes.
Am I audible?
Yes,
Yes,
लेकिन थोड़ी आवाज टूट के आ रही है.
Sir, connectivity.
Yes.
So you can't hear me now.
Voice is a little bit cracking, sir. Voice is cracking.
Ravi, आपकी आवाज थोड़ी टूट रही है. Can we put this question to Sudhir?
Sir, there are two questions.
Yes.
One is to reduce the use of medications.
Yes.
And he is apprehensive that they may have some side effects. So I would like to emphasize they have minimal side effects. As far as the medicine is concerned, we prefer inhalers over oral medicines. As inhalers go to a very localized organ through mouth, they go to throat and then to lungs, and they come back. So the organs affected are mainly mouth, tongue, and the throat, for which we have got major side effects, that is not major side effects, the minor side effects, but majority of patients may feel some crackling sound because of deposition of drugs on the vocal cords, or some patients may suffer from oropharyngeal candidiasis. That can be taken care of by rinsing the mouth thoroughly after using inhalers, especially after using inhalers which contain steroids. After rinsing the mouth immediately after taking inhalers, so these side effects can be minimized and can be avoided altogether. As far as dose of these medicines concerned, by using proper technique, a dose of medicines can be reduced, and it has to be taken into fact that there are few environmental factors. Those environmental factors, if we can take care of, then definitely those can be reduced further. And the doses which we talk about in inhalers, they're in micrograms, not in milligrams, unlike tablets. And 1 microgram is 1,000th part of a milligram. So those are very minimal already. But to further reduce it, one has to take care of environmental factors also. And the second question was regarding influenza vaccines.
Right.
So whether it is beneficial in asthma or not. So here I will like to submit that any infection anywhere in the body will lead to generalized inflammatory reaction in the body. So that will affect asthma also. So similarly, it happens with all the viral infections. So influenza vaccines, of course, they take care of influenza infection, that is infections by influenza viruses. And they are not per se affect asthma, but by reducing the respiratory infection, influenza infections, and reducing the respiratory infection, they are beneficial in asthma in that way that infection is not there and asthma is not exacerbated. and it is of great immense help in reducing the episodes of exacerbations.
Right, sir.
Thank you very much.
One last question, Dr. Sahab. Is inhaler better or nebulization?
So both are same things. They are inhalers
Okay.
like the MDIs, pasteurized inhaler, the DPIs, that so-called rotacaps, and the nebulization. They contain the same medicine and equivalent dose
Okay.
and same route
So
of administration. So it depends on the patient comfort levels, patient competency, patient's level of understanding, availability, economics, and so many other things, sir. But everything is same, sir, equivalent doses.
either of them can be taken.
Yes, sir.
Okay, sir. Okay, sir.
And now
Thank you.
over to Dr. Agrawal. Kindly
Yes.
conclude this webinar. Thank you, sir.
I think we had wonderful discussion. As a moderator, I am very satisfied. And I'm sure my
All right.
friend Sherwal, Dr. Sherwal will also agree.
Thank
So
you, sir.
there, thank you, Sherwal. Thank you, Gupta ji. Thank you. I think Ravi, are you there? Vinny, they have logged out. So,
And thank you very much.
Thank you, sir. Thank you very
तिवारी
much.
जी,
Yes, sir.
ये
Yes, sir.
ये केवल बिगनिंग है.
Okay, we will continue, sir. Don't worry.
ये बिगनिंग है. अब आपको इस पे एक वो निकालना है पूरा
इशू निकालना.
इशू निकालना है. उसमें
Hmm.
सबसे आर्टिकल्स लेने हैं.
Right.
Somebody should be the lead person. He or she will decide कि कौन कौन क्या है. And then
Right.
इंटीग्रेटिव मेडिसिन का भी एक एक्सपर्ट चैप्टर होना
Yes,
चाहिए
yes.
उसमें.
Why not? Why not?
And then your effort should be, आप पत्रकार हैं, आपको
Right, sir. Right.
गवर्नमेंट को भी बताना पड़ेगा
बिल्कुल
कि
सर.
इस तरीके से हम इसको कर रहे हैं. आप इसको अपनी पॉलिसी में, डॉक्टर शेरवाल ने बताया कि डेडिकेटेड वे में हम पॉलिसी को बनाएं. ठीक है.
Right, sir.
So again,
And
thank you.
one more request we have with the Major General Krishan Chauhan sir. Krishan Chauhan sir, do you have any question? You can put it.
जनरल साहब, वेलकम. आपकी आवाज अनम्यूट.
Kindly unmute.
Thank you very much. It was very interesting, especially the integration in Ayush. I was very happy to hear that it is in progress. In fact, much before my wife had joined, she's also a doctor, and she had joined in AIMS itself the program of effects of yoga on hypertension, the way back in 2022.
तो ये सब गुप्ता जी आपकी देन है.
So now that Mr. Gupta has already done so many years, and I am a very old retired man now, but I was very happy to hear that it is in the pulmonary side, and now you people are recommending in the cardiac side also. Thank you.
That's right.
Thank you, sir.
वैसे जनरल साहब आप इतने ओल्ड लगते नहीं हैं. We must learn something out of you. So thank you very much.
Thank you, sir. Thank you.
Bye for now. Thank you.
Thank you, Amrish. Thank you.
Thank you, ji.
Thank you all, sir. Thank you, Amrish.
Thank you, everyone. Thank you.